Okay, thanks for joining us, everyone. Welcome to Grand Rounds at OpenNotes. This is Improving Portals for a Better Patient Experience. We have a great panel. We're really excited to share this webinar with you today. Before we get started, there's just a couple of housekeeping things to keep in mind. First is you will be in listen-only mode for the entirety of the presentation. But if you need to ask a question, and we encourage you to do that, please use the question box to type your question there, and we will address all of the questions at the end of the presentation during the Q&A. Also, during the Q&A, if you want to ask a question out loud, you can raise your hand with that little hand icon, and one of our organizers will unmute you so that you can ask your question. So please ask any and all questions. We'll be excited to address those at the end. And now I'm going to turn it over to John Santa, our Director of Dissemination, to do the welcome and introductions.
Thanks, Amanda. So welcome, everybody. Thanks for coming, and thanks to our speakers. You know, I can't help but think this morning, many of us are looking forward to the interoperability rules that will soon come out from ONC, and we're seeing a really evolving discussion about access to information, and with some hurrahs for third-party apps and other folks expressing concern about them. You know, as I look at that, I think, what about portals? And whether some of that activism should be channeled at making an existing option for patients much better. And that's what this conversation is about this morning. I've had the pleasure of hearing these presentations back in August at a workshop that OpenNotes and ONC co-sponsored. And we thought that it would be great to repeat these presentations. So I'm thrilled today to introduce our four speakers. Three are from Emory. Julie Hollberg is the Chief Medical Information Officer at Emory. Shannon Caul is a manager in clinical informatics there and has focused on the portal. And Elizabeth Sprouse was at and still has a relationship at Emory, but now also has a company called Double Lantern. So we really appreciate those folks coming. I'm also thrilled to introduce Rosie Bartel. Rosie is a patient advocate, patient activist. Her background really is decades of experience in education, where she focused on improving the education system through measurement. When her health situation activated her and she began her advocacy career, she used much of what she learned to advise multiple health systems, and now a electronic medical record vendor. And Rosie has been involved in a wonderful patient and family advisory committee started by PFCC partners and OpenNotes, and helped to organize the work that you're going to see. So with that, let me turn it over to the Emory team and go for it.
Good morning. This is Dr. Julie Hollberg, and it's a pleasure to be presenting with Shannon Caul and Elizabeth Sprouse. We are very passionate about patient portals and improving our portal at Emory to create a better patient experience, and look forward to sharing our approach with you today. Next slide. So we had two real objectives. We wanted to show you how we've developed a scorecard and how we use that to score patient portal based on the likeliness of patient engagement. And then we wanted to also show you how we've used our scorecard to help inform our improvement initiative. Next slide. Just to give you a little bit of background about Emory Healthcare, we're a large health system in the Southeast. We have 11 hospitals with almost 2,700 beds. We also have a very large outpatient footprint. We provide comprehensive outpatient care throughout Georgia and had 4.7 million outpatient service visits last year. We've got 2,800 Emory employed and private practice physicians that work in our hospitals and in our clinics, and they practice across 70 specialties. In addition to that, we have 23,000 staff, so we're a large organization. I also wanted to give you a little bit of background about our patient portal team, just so you could benchmark what are the resources that we have at our disposal to help improve patient portal, and also give you a little bit of info about our patient portal statistics. So we look at enrollment, and we have almost 475,000 unique patients that are enrolled in our portal. But beyond looking at enrollment, we also really focus a lot on utilization. And so we look at how many unique users we have that are logging in and active on our portal every month. And we average, in FY19, we average 93,300 unique users per month. We acquired 3 new hospitals and a new provider medical group in June, and anytime we have a big influx of new patients, it really increases our enrollment as well as our calls. We, a few years ago, were able to successfully negotiate for a centralized patient portal support team, and that team consists of 2 full-time call center agents, and we take around 1,500 calls per month spread amongst those 2 agents, and they're answering calls related to enrollment as well as when patients have challenges, sometimes navigating the healthcare system or navigating the patient portal. We have a full-time portal project manager that we were able to secure as part of a philanthropic program, and that project manager focuses exclusively on patient portal initiatives and reporting. We're very data-driven at Emory and focus a lot on measurement, and so we have lots of reporting we have developed and help to disseminate to our clinicians in different specialties. And then lastly, the patient portal team rolls up to 1 full-time manager, and she spends 20% of her time dedicated to the portal, and that's Shannon Caul, who you'll also hear from today. Next slide. So it's my pleasure now to turn it over to Elizabeth Sprouse, founder of Double Lantern Informatics, who really did the work in developing the scorecard.
Hi, everybody. I'm so excited to be here with you today and share some of this information. So for the next few minutes, I'm going to talk about the development of the scorecard, and then we'll go into the case study with Shannon and Dr. Hollberg on how they've applied the scorecard within the Emory Healthcare organization. So the purpose of developing this scorecard was to develop a way that healthcare organizations can evaluate their patient portals based on likelihood of use. So not does it improve patient outcomes or patient engagement or activation, but, goodness gracious, are patients going to be able to sign up and log into the portal, and then will the magical things that they want to be available in the future be waiting for them once they log in? And a lot of this came out of the fact that although patient portals are becoming, really standard in healthcare, we don't have a very good way of measuring scorecards and if it's giving patients access to, to log into their healthcare information. And healthcare systems have a lot of competing priorities. There's only so much money to go around. So when you are looking at your long-term roadmap for a patient portal, you need to put your efforts that are, where you can move the dial on making sure that you're engaging patients electronically through a patient portal. So to conduct this study, 2 things happened. I won't dig into all of the kind of the academic rigor of this particular study, but it was fairly simple. There were 2 components: an academic literature review, as well as qualitative phone interviews with healthcare executives across the United States. So those phone interviews were really the linchpin in developing the scorecard, because although there's a lot of great literature out there, there's not a ton that's published around patient portals, and a lot of times the people who are down, the boots on the ground doing the work that have that information that can help inform change don't have time to publish. So that's where those phone interviews came from. From the academic literature review and the phone interviews, I did basically a frequency distribution of how many times things were mentioned as being linked to likelihood of increase of patients using the portal. So next slide. So from that, the next two slides, I don't expect you to read through them, but this will give you a count from the literature review of those features and organizational elements that were linked to increased likelihood of use. And the point of showing you these two slides, and you can advance to the next one, is really just to show you that there are so many different things for a healthcare organization to consider when they're looking at moving the dial on increasing likelihood of use. Amanda, you can go to the next slide. All right, great. So from this, and advance to the next slide if you would, I just want to highlight a few things. Of the of the features, the highest ranked feature with around 21 of the references citing it was personalized content that helps with disease management. So messages, education, recommendations, and care plan. And the second highest ranked feature was secure messaging. Next slide. Of the design and organizational adoption elements, the highest ranked feature was simple design and use, and ease of registration and login was also significant. Next slide. And of the operational efforts, because it is not all just what's in your portal, you have to look at things like user training and having technical support available for your patients as well. All right, next slide. So at the conclusion of this study, before I show the actual scorecard elements, it really became clear, and I think we could have made a hypothesis about this in the beginning, that there are two key phases of portal adoption: your initial enrollment in and adoption of a portal, and then sustained use over time. So you have to make it easy for folks to be able to log into a portal, and then the things that they want need to be waiting for them there. Okay, next slide. So now real quick, before we go into the example with how things have gone at Emory, I want to show you the components of the scorecard. So over the next few slides, I'll show you the different sections of the scorecard. You'll be able to see that each section works the same. So you've got available points, and then a healthcare organization would either simply enter a 1 or a 0 if they have that particular feature or item, and then those would equate to the points earned. The points earned, you can see, are different for some of the different features, and that was because I used some logic behind the scoring regarding whether things were mentioned a larger amount of time within the literature review, and whether the qualitative interviews also reinforced a feature or an element as being linked to increased likelihood of use. So you can see on this screen, you've got features. So if you were to go through and do your scoring and see that you didn't have personalized education, maybe that would be something to work on. So you can use this to inform your technology roadmap going forward. So you have a features section of the scorecard. Advance the slide, please. Then you have a design section of the scorecard. So this is things like large font, images and illustration, icon-driven, assistive technology, so things regarding vision impairment help, simple and easy to use, as well as a content understanding section. So are you addressing health literacy with things like disease information, medication and side effect explanations? Advance the slide, please. And then the final two sections of the scorecard are technical aspects and assistance, and operational. So technical aspects, is it easy to register and log in? Do you have a single portal for the organization, limited downtimes, technical support available? And then the operational side. So not only are you conducting campaigns toward patients to get them to enroll in your portal, but you also have to have the other side of that, the organizational support. So you're involving your providers, your staff, and your clinicians in portal launch and sustainment. So the way that this scorecard works as a healthcare organization, you can see they can get individual scores for each of the sections as well as an overall average. And that overall score, that's all great, but where kind of the rubber meets the road are in those individual scores, where they can see at a very granular level those things that they might want to put into their strategy to implement in the future. Okay, please advance the slide. I'm going to hand it back over to my Emory colleagues to go through a case study example of what they've done.
Thank you, Elizabeth. Good afternoon. This is Shannon Caul. For this presentation, we're using a case study that we performed in 2017 and then re-performed in 2020 to gauge the improvements we have made. Emory Healthcare has 3 patient portals that are driven off the particular EHR. Our Blue Patient Portal is the largest portal that comprises our hospital and faculty physician practices. Our Gold Patient Portal is for our non-faculty outpatient physician practices. However, we have had several of these transition over to the Blue Patient Portal within the last 2 years, and our iPortal provides access to the Emory Eye Health Records. For the scope of this presentation, however, we'll be focused on the Blue and Gold Patient Portals. As you can see on this slide, we do have some of the Blue and Gold features of our portals listed. One of the real exciting ones that we implemented this summer was the Fire Patient Access. So now we're also able to connect to Apple Health, which is a real big achievement for us. And then we also have the basic or standard functions, such as the release of labs within 36 hours, radiology reports within 72 hours, deep heart visit summaries, secure messaging, and prescription renewal. Next slide, please. The next few slides focus on our original scores from 2017. And just some noteworthy items on this slide. We didn't score well in the results lab and radiology because we did not have pathology results flowing into the portal. And we also, while we did have a visit summary, we did not have clinical notes on display in the portal as well. Under the design category, we do have some large fonts in some areas, but not in all places. And we did use or involve our patients in design and testing, but not consistently throughout. On the next slide, please. Just to go over some of our other original scores, for test purpose and interpretation, we do have reference ranges listed for our results in the portal, but we do not include a purpose or reason for the interpretation. And then also just to highlight, some providers did include education in some of the visit summaries, but it wasn't consistent throughout. So now that we've done this first initial assessment, what did we do with it? And so one of the first things that we did was we broke out the elements within the assessment based under what was under the span of control of Cerner as our vendor, and then what was under the span of control of Emory to be able to influence and focus. And so on this slide, this just focuses on some of the elements that are more under Cerner's control, such as design elements, browser agnostic, easy to register and log in. One of the things that we did do, even though we categorized these elements under Cerner, we work with Cerner each fall with a planning meeting to understand what improvements they have on their roadmap, and then how can we also partner with them for testing and being able to adopt these features to be able to improve our assessment score. On the next slide, these are our Emory elements. So some of the things that we can do as an organization to improve our score is to implement OpenNotes, pathology results, implement or turn on the health record or the health dictionary functionality. One of the huge wins that we could do is have one single portal, which I think everyone would jump up and down for. And then also do more patient awareness campaigns that are consistently throughout. A lot of times we'll do patient awareness campaigns for a new feature or enhancement, but not consistently throughout to help patients, to remind patients about the benefits of the portal. And then also ensuring our provider involvement is sustained throughout. One of the great things about the timing of when we did this assessment, it was towards the end of our fiscal year in 2017. And so what we did is we used this exercise as a tool to assist in driving our strategic action plan and goals for the next fiscal year, which Dr. Julie Hollberg will explain on the next few slides.
So when we think about Patient Portal and setting up our strategic plan, we absolutely use the scorecard, and I'll walk you through how we've used that to do some targeted initiatives. But we sat back and at the inception of our portal and thought about what are our goals, and really taking a 360-degree holistic view towards the portal. And what I mean by that is that we think about all of the users of our portal. We have found that one of the best predictors for patient experience and patient engagement is the recommendation of the providers and the clinical staff. If a patient goes to a clinic and the physician or the APP talks about how much the patient could benefit from the portal, we found they're much more likely to engage. And so as we target our improvement efforts for patients, we have an area of our goals dedicated to provider and employee experience. We also focus on patient outreach and the patient experience, and then the technical innovation specifically around the features. And then underlying all of this is analytics. So as I mentioned, we're very data-driven, and in order to be able to measure our improvements, it's important for us to have a strong analytic infrastructure. So these are the 4 categories of our goals. And then for each of kind of our categories on the next slide, you'll see that we have initiatives. And these initiatives, you can relate these back directly to the 4 different areas of the scorecard. So we really sort of do a matrix approach between our goals as well as using the scorecard to help improve the portal. So in this fiscal year 20, we're focused on adding pathology results, doing an OpenNotes pilot. All of us today on the phone are huge proponents of OpenNotes and appreciative so much of all of the work that the OpenNotes project has done. And unfortunately, amongst my colleagues, there still is a lot of anxiety and reservation, even though patients absolutely have a right to have all of their notes and they can get them easily going through medical records. There still is some trepidation that we're working through to get them onto our portal. We also focus on improving our design, and as Shannon mentioned, we have elements that we can control and elements that we're dependent upon Cerner to control, but we're focusing with our patient family advisors on our material development to, again, continue to improve our patient education and the information, not just for disease management, but also on portal utilization. And then obviously we also are focused on content and operational improvements as well. Next slide. So now what I will walk you through is the scorecard for where we anticipate that we'll be at the end of 2020. We're halfway through our current fiscal year, and the areas highlighted in green are ones where we went from previously having a 0 to now having those features on our portal. So as we mentioned, we'll be doing more on care plans. We'll be piloting to have OpenNotes and more visit details. We'll be working with Kairos to have scheduling integration, and we've gotten much more robust in our partnership with patients and their involvement in design and testing. Next slide. And then obviously on the content, we've made some significant improvements in terms of our terminology dictionary and having more explanations around medications. And then we're also, from an operational standpoint, going to be doing some targeted patient awareness campaigns to help our users become even more engaged on the portal. So if you put that all together, you can see where our scores were in 2017 in comparison to where they were in 2020. And as we alluded to throughout the presentation, organizations are run on very tight, healthcare organizations run on very tight margins and have challenges in getting resources for all the variety of really important initiatives. But if you able to get a few resources and focus even on just moving the needle on 4 or 5 of the elements within the scorecard, you can see that you can really make some significant improvements, particularly over time, related to your patient experience in using patient portals. So with that, we hope that you have enjoyed our presentation and have a better understanding of how the scorecard was developed, as well as how we have used that scorecard to develop and inform our strategic plans. And after Rosie's presentation, which we're really looking forward to, we'll be happy to take any questions.
Good afternoon. This is Rosie Bartel, and I am going to give you the patient's perspective on portals. First of all, my reason for being so interested in portals is because at this point I have 7 portals. And of those 7 portals, I use 1 all the time, and the other 6 I use to get test results. And this is why. First of all, my story began 10 years ago in 2009 when I had a knee replacement that turned into a MRSA staph infection. that led to 55 surgeries, over 200 hospitalizations. I went into septic shock more than 12 times. I have had an amputation of my leg above my knee, then the amputation of my hip, and then part of my pelvic bone. Because of this, I've had multiple hospitalizations, because of multiple doctors, because of multiple things happening to me. I had to look to my portal as being a help, but many times it wasn't a help. It was more of a hindrance because it made me frustrated. I can tell you that a portal can only be helpful if it is a good for everyone. Because of this, I got very involved with a group that John mentioned in the beginning. It's the National IT Patient and Family Advisory Board. And this board is looked at the portal from the patient's point of view. Next slide. A portal by a patient to inform collaboratively with healthcare to improve the portals for all. That was our objective. We called it the P3 project, Perfect Patient Portal. And in this project, we looked at data from surveys. We had 60 responses to a survey. 41 of them were from Epic, 13 were from Cerner, one was a homegrown, and 21 we didn't know where they came from. We could identify health organizations, but not where they came from. Next slide. This project that we did, this survey told us that the things that were most desirable was number one, communication, number two, test results and lab results, and number three, appointments. For me, I'm going to tell you that test results are important. Appointment setting and being able to do it is important, and to set up my appointments is important, but communication is key. I can tell you that at times I've had doctors disagree with treatment, and I was the go-between between doctors. And I'm going to tell you, the only time that I've ever been able to handle that well is when I had my OpenNotes. In the portal where I have OpenNotes, I can take the note from one doctor and take it to the next doctor and say, this is what I heard, this is what he said, here it is in black and white. Because when a patient is caught between two doctors, and one is saying do this and one is saying do that, you don't know which way to go. You are living with two doctors living in their silos, and you are caught in that walkway between the silos. And the only way you can cross that walkway is be able to communicate. And you can't communicate if you don't have notes. And I'm going to tell you, the OpenNotes was my saving grace in those communication situations. And yet it was also my downfall when I didn't have notes. I literally changed hospitals and physicians at one point because I couldn't get from one silo to the other. And when you're sick, the last thing you need in this world is to have two doctors that won't communicate with each other, and you are the person caught in the middle. So I'm going to tell you, communication is the most desirable feature. Next slide. But the least desirable can also be communication, because when your portal doesn't provide the things you need to communicate to the next person or to communicate with others, or you can't get the information you need through your portal, you then become very frustrated. So I'm going to tell you, if that silo that was operating between these two doctors, because I didn't have a portal, I couldn't communicate. Technology is another whole piece that is very frustrating for patients. When the technology is impossible to use, it's impossible for them to pass, to be able to get from one point to the next point to the next point. And interoperability, when you can't use that technology between your home computer and your handheld mobile device. Basically, for me, I only use iPads and iPhones because of laptops don't work well for me, and sitting for long hours in front of a computer in a wheelchair is hard for me. So being able to use my iPad and my mobile phone to get to my portal is so important to me. Next slide. So basically, one of the things that our P3 this came up with is a perfect patient portal would be centered about me. It's not about what is good for only for healthcare providers, but it's what is good for care providers partnered with experience for patient and family. It's from bedside to boardroom. It's from that patient-centered care is in a partnership in the design, the program, and individual plans for providing the best outcomes for their patients. And as you look at measurement and patient-related outcomes and how you measure them, you have to be looking at how these portals really look at how it will improve patient care and how it will improve patient outcomes. And I'm going to tell you, I'm a better patient when I have good information. Next slide. Accessibility. As you can see, I want the concept of accessibility is it needs to be accessible to everyone, every which way, and every way they can. It cannot just be connected to computers, but not mobile devices. Next slide. Also, the concept of the landing page. That landing page has to have everything you need and everything you want at your fingertips. It has to be easy to find, easy to connect with, easy to locate. I'm going to tell you my favorite portal. I can make an appointment. I can check in for my appointment. I can update my meds on that appointment for that appointment. I can update my insurance cards for that appointment. I can do everything for that appointment long before I walk into the door. So when I get to the doctor has all those things updated. I don't have to fool around with paperwork and things. When I get to the doctor, I can only deal with things that really matter to me. And that is those things that are mattering to me on that day, not those things that are important and behind the scenes. Next slide. The concept of the personal profile. You need to know about me. You need to know more than just my name and my meds and what's wrong with me, but you need to know what matters to me. What is the activity level that's important to me? What are my health goals? What are my concerns that day? And that, a portal needs to be able to give you that information so that when I walk in the door, you're ready for me. The other piece is that personal information needs to know who is also part of that picture, who else is part of my portal. Next slide. Then communication. I'm going to tell you that one of the big uses that I got in communication from my portal that I love is that it was not only communication from them, but I also could communicate. If you ever look at my husband's phone and my portal, you will find tons of pictures of a wound that I was healing. And because I didn't want to go drive 2 hours every time I had a concern about the wound, I would take a picture of the wound. I would write a scenario of what I was concerned about, and I would send it through my portal. And I can tell you that because of this portal and because of how well it was managed, I would get an answer back within an hour of should I come to the doctor and have it looked at further, or should I add something to my wound care at home? Or I got an answer. I didn't have to wait. So the communication cannot only be one way. Yes, I want my open notes. I want everything about me in that portal, but I also want to be able to ask questions about it. I want to be able to communicate with my physicians, and I want to be able to get answers. Next slide, please. Then it needs to be able to help me. It needs to be able to give me help for the portal. I heard that Emory talk about that highly, that is so important to give that technical support. You need to be able to give patient support. I just gave you a story about that. The support of how I can get better deal with my wound. And then education. And I know that, so many times we go to the internet, and maybe not the best internet to get information. I would love to go to my portal and get the best information, the best education about what I'm concerned about. And it may not be the same thing every day. So don't hand me a piece of paper about my wound, and that's you think is the only thing I'm concerned about, or about MRSA, and you think that's the only thing I'm concerned about. Patient education piece should be able to get information about all the things that might matter to me on any given day. Next slide. I want to thank you for hearing my story, hearing why portals are so important to me and to other patients. I believe portals there's a lot of work being done by the companies who develop portals and by hospitals that use them, but I think you still need to keep hearing the patient's voice and make sure that the patient's voice is involved. I am involved at this point with one of the providers of portals. I'm on their advisory board, and it's been a real eye-opener about how much they don't know about patients. Thank you again for hearing my story.
Thank you so much, Rosie. Thank you to our presenters from Emory. We are moving into our Q&A section, and I just want to remind everyone or inform those of you who just showed up or who showed up late. You can raise questions in the question box, and we will address those out loud. You can also, at this time, raise your hand by clicking the little raise hand icon, and we have a staff member who will recognize you and unmute your line. Once you're unmuted, you will have to also unmute yourself. That's just the fail-safe so that we don't accidentally unmute people who don't want to be unmuted. So when we unmute you, you'll also need to click unmute. And with that, I'm going to hand it over to John and to our staff members, Liz and Deb, to facilitate our Q&A.
Thanks, Amanda. First of all, let me say that there are some good questions that are lined up on the question list, and I'll turn this over, I think, to Liz, and if not Liz, Deb, who will go over those questions. I will mention the first one, Amanda, because it's to you. Can we download the slides? Can you tell folks about how they can get access to the slides?
Yes. After the presentation, we'll make the recordings available, and we'll also make a PDF of the slides available. So everyone who registered will get a follow-up email after this webinar with the recordings and also a PDF of the slides.
Okay. Liz, do you want to start moving through these questions?
Yeah, I'll just respond by saying Deb is going to be handling the chat box questions, so I'll hand it over to her. But I did want to say, if anyone wants to verbally ask a question, just raise your hand, which is in the box to your right. So Deb, I hand it over to you.
Great. So the first question that came through relating to the scorecard, in addition to being browser agnostic, how important did you find it to be device agnostic, for example, tablet or smartphone versus a PC, or app-based versus browser-based?
Hi, this is Elizabeth. So I'll address that. I would say that the literature was showing being device agnostic as well. One of the challenges was trying to find literature that was, most recently published, where I think that would pick up on. So it didn't quite make the scorecard, but that is absolutely of significance.
And that question was from John Keys. And then a question from Madison Beatty. Were these scorecards developed with the input of patients or only providers?
This is Elizabeth again. So that was one limitation of the final research product, is that we didn't do interviews with patients. So the input from patients would have been from the studies that were conducted that were used in the literature review articles, as well as the input from the healthcare leaders across the country that we did during the qualitative phone interviews. So not direct interviews with patients, but definitely from within the source of what was included.
And another scorecard related question, did you get any input about timeliness of patient data in the portal? For example, sometimes data is released to the portal immediately as it becomes available, whereas other times patient data is not released to the portal for a day or two.
Right. So most of the studies that I looked at did not go into the exact hold time of data. However, we have big experiences with that at Emory. So I just want to look to either Shannon or Dr. Hollberg to talk about the release time.
So I personally think the sooner you get the data into the patient's hands, the better. However, there is another viewpoint from some of my colleagues that it is better for patients to receive data and results in the context of a conversation or a message rather than directly on the portal. And so I think, that one area where we struggle in is particularly with oncology patients and, whether it's what is the best care if they're going to have a negative finding for it to come via the portal or for it immediately released versus time for the physician or APP to give that patient a call and discuss the result. So it's something that we continue to struggle with. We initially started with a week, and then as my colleagues with results released for radiology and lab, and as my colleagues realized that there wasn't harm, then we continued to slowly push that back. And then, and that's how we ended up at 36 hours for labs and 72 hours for radiology, trying to strike a balance between those providers who want to be able to have time to call patients versus not making the receipt of results entirely based on the clinical care team's convenience and when they get to it.
And another question for Emory, what process did you use to get patients involved in design and testing? Was it random outreach or marketing for volunteers?
So we have a robust group of patient and family advisors, and we look to that specific group of patients. So it's those patients that are involved in our formal program.
This is John. Can I just make an editorial comment? We hear so much skepticism about whether patients can contribute to this process, and it's great to hear that response from Emory. Recall Rosie's comments. Patients can be incredible participants and governors, in this process. And please, it's really frustrating for us to see in some places how little involvement patients have. Sorry. Go ahead, Deb.
Another question for Emory. How many people and who, in terms of who was involved, rated the portal scorecard?
And so clarifying question on that, is that how many people were part of the project to use it to score the portal?
Yes, it was a small group of us. So it was Shannon Caul and Elizabeth mainly, because it really was a matter of yes or no on do we have features or not.
And another question for Emory was, who does the portal team roll up to? Which department does it live in?
So the portal team lives in clinical informatics, which is my department, and rolls up to me as the CMIO.
And I will say that I saw across my qualitative interviews, it was often, the portal is often kind of, I won't say dumped, but handed on the CMIO at organizations, kind of as another duty as assigned. And it's a testament to Emory that they've been able to build the case to actually have a team to make work possible.
Yeah, I have a really close partnership with the chief nursing informatics officer, and there's a variety of things where we take turns who has the lead. So even though it rolls up to me, there's also a tight partnership with our nursing colleagues.
Another Emory question. Oh, sorry, somebody else.
Yeah, I just want to remind folks that if you do want to verbally ask a question, just raise your hand. And then I did want to shout out, we got a number of comments in the questions area that aren't questions, but a ton of praise and thanks to Rosie for your presentation. Folks saying excellent presentation. People who say they're pounding on their desks in support of Rosie. One of the best patient voices I've ever heard. Powerful arguments and well expressed. So just want to share the love there. Back to you, Deb.
Another question for Emory. How did you add information about why tests were ordered? Did you attach diagnosis codes?
We don't have a ton of information about why those were ordered. As part of radiology results, they will have the reason for exam as part of that report. So that's just a standard field as part of the report, but we haven't done custom work related to that.
And I think you might be also asking then too about the education that Shannon's working to add with links to health content about like, what is this test and why is it typically ordered? Likely not directly linked to that patient's diagnosis code.
Correct.
And then here's a question for everyone. So maybe Rosie can give her perspective first and then the Emory folks. Our providers and care teams are being overwhelmed by messages from patients. How has Emory managed this? What is the patient perspective? How should we manage patients who submit 1,000-word questions? Rosie, do you want to respond first?
Well, I guess for me, when I send a message, it is the clinic has, or the doctors have a nurse that looks at it. They also know their patients. They know patients who ask the reasonable questions and then kind of waylay those questions that are not emergency questions and push those off later. I think that, managing the questions should not be stopping the questions from being asked. You might use a scribe to help manage those questions. You might use, an intern to help manage those questions. But I think the questions have to be able to be asked, because if you don't give the chance to ask the questions, you've cut the patient out of that side of communication.
This is Dr. Hollberg. I'll chime in a little bit from the provider perspective, and then Shannon can talk about the portal. So I absolutely agree with Rosie that the idea is not to shut down those questions, but it is about making sure that you address and answer the patient's questions in the right environment. And so we encourage our patients that the use of the portal is for shorter questions, not for urgent things like, chest pain or shortness of breath or severe depression. And so we have limited the words now at the request of our providers down to 500 words. And our providers will sometimes respond and say, that we need to have an office visit so we can have a face-to-face conversation about these questions.
And from a technical perspective too, we have the portal messages routed to different clinical routing tools, so they can be triaged to then be forwarded to the appropriate person. So there's not messages going to the incorrect folks to answer. We also, for some messages that provide some standard messages that providers will send to patients, we've disabled the ability to have reply all. So patients will have to start a new message that will then get routed appropriately based on their questions. So it's not just an influx of reply all emails that go back to the provider.
I would say, and just as one final comment, I would say we have some providers that complain, but not a lot of providers. It's a minimal amount of complaints that we get in terms of being overwhelmed by the messages. And I think that, really goes to show about it can be a very effective tool, particularly for having, asynchronous conversations. So you don't, instead of trying to get hold of the doctor or trying to get a hold of the patient and having 3 or 4 wasting your time doing 3 or 4 phone calls back and forth, patients can ask their questions and then, get responses from the provider. And we really use that multidisciplinary approach where we have nurses and providers manage the messages as one of the ways or one of the strategies to decrease the burden.
This is Rosie.
This is John. Just a comment. From a notes perspective, we hear overwhelmingly that this doesn't happen. and that when it does, it is predictable which patients are going to ask a lot of questions and ask long questions. That said, it would be incredible to have some data. And to the Emory folks, as I look at what you all did, which is incredible, and you were adding improvements, it would be wonderful to get some sense of which, if any of these improvements, did result in a barrage of patient questions, and which didn't. You know, one of the great things at Emory is you're data-driven. Boy, is it unusual for us to see informatics folks be data-driven and know, you know, when we did this, well, what happened? Okay? Just a comment. Rosie, were you going to make a comment?
Yes, my comment was, you know, I'm thinking of all the questions that I might have asked over the last 10 years through my portal. And I can tell you that I don't believe any of them were more than 50 words, because a good question, a question that's important to a patient, shouldn't be 500 words even. It should be less than 100 words, because you can ask that question very concisely, and then it'll get to the right person, and then it'll be easy to answer. And I think, you know, if you have a patient that's abusing it and asking, you know, using it just to ask every silly question or every question that you just to get attention, that's a different ball game. And then you address that patient's concerns. I think you have to know your patients, and that's the key. Know what matters to your patient, know your patient, and why they're asking the questions.
Go ahead, Deb.
Another question about Emory's portal. How many languages is it available in? For languages the portal may not be able to fully be translated in, what are you doing to make the portal effective for patients who do not speak English?
So currently, we only have it in English. It can be available in Spanish. And then through the use of our Patient Portal Contact Center, we use translation services to answer patient questions that are incoming.
Rosie, a question for you. They said, thank you for sharing your experience. What do you think about expanding the portal so family members can also communicate on the portal?
I think that the best way to do that is if the patient gives a proxy to a family member, and then that family member can ask questions because they have a proxy to the portal. You know, I mean, I let my husband ask questions through my portal because, you know, basically he was looking at the wound. I couldn't see the wound. So then he would ask the question, but I just let him ask the question because he was my partner, my caregiver. But, you know, I think proxies through portals might be the answer of letting people ask questions or not ask questions.
Has Emory explored disparities in portal enrollment and use by race, ethnicity, language, sex, etc.? Nationally, there have been disparities identified in portal use.
And I'll chime in before I hand it over to Shannon. This is Elizabeth. So in the research that was conducted in the development of the scorecard, what was really interesting is it showed that across, you know, different ethnicities and races and socioeconomic status, there was not a difference in whether people wanted to use a portal or not. However, where the issues then come up is kind of the crux of this question is on the healthcare side, actually making assumptions on behalf of the interest of those patients and not offering access is what some of the literature has shown as being kind of the downfall there. Shannon or Dr.
We haven't done socioeconomic or racially targeted projects. What we've done instead is take the approach that Elizabeth was alluding to, that, you know, our assumption is all patients are interested, and so we make sure that all of our sites are educated about how to enroll and are educated about the support services that are available through our contact center.
And this is John. I just want to mention Mount Sinai in New York. We've got a grant from the New York State Health Foundation, and with that money, hired a Spanish navigator. And we just looked at their results. The Spanish navigator enrolled hundreds of Spanish-speaking patients into the portal. So that's certainly a suggestion that, you know, if you build it, they will come.
Yep, I totally agree.
A quick question for Emory. What delay do you have on pathology results being released?
It's on our FY20 plan to add pathology results to the portal, and we will probably start at somewhere between 3 and 7 days, depending upon the provider's comfort level. We've done everything that we started with at 7 days and then decreased the time, just to kind of ease the results in to manage some of the concerns or the expectations.
And then with multiple portals frequently comes patient confusion. How have you managed these issues so that patients know which portal to use for which purpose?
So we try to communicate that as effectively as we can through our patient education materials, and we know it's confusing and it's a struggle, and that's why we have the centralized patient contact center. When the calls went through our large central contact center, we had a wide range of knowledge and thus a wide range of experiences for our patients when they asked their questions, because when you're talking about hundreds of call center agents, it's hard to have them all educated on the nuances of the portal. So by moving to a call center that's focused solely on the portal, we've been able to increase the availability of resources and the quality of the resources that we have for patients to get help. But we know it's confusing, and we wish it wasn't like this.
This is John. The time, I think, is approaching the end of the hour. There is a question further down I want to make sure we answer. The question is, did you have orientation training for patients to be involved like Rosie? Any suggestion to help get Rosie clones? First of all, on the OpenNotes website, there's a toolkit for patient and family advisor councils, which is the major way at OpenNotes we've tried to find and orient and educate patients in this process. And again, when an organization makes a commitment to do that and do it well, it works well. There are several that have done that. UCLA, for example, has had a PFAC devoted to IT issues for 2 or 3 years. There's 2 national, 3 national groups that have been following IT issues and what's going on here. We've worked a lot with PSCC partners, and they helped organize the PFAC that Rosie is on, and they definitely know how to work through these issues. The Institute for Patient and Family Centered Care, IPSVC, Bev Johnson's organization is also very interested in this issue and trying to help PFACs. And Beryl has had several sessions on OpenNotes at their national meetings. Rosie, any comments about that?
My comment is that I think that I keep saying patients have volunteers, or hospitals have volunteers, patients and families volunteer at hospitals, and I think you can find champion volunteers who would be great at helping people develop the use of portals. So I think that, I think that sometimes we don't use our volunteers in hospitals and clinics the best as we can, and we could be using them to help patients learn about their portal. I believe portals aren't being used as much as they could be because people don't understand them or don't see a reason to use them. If you give me a reason to use something, I will use it. And so that is the whole reason why people don't use it, is because they don't see a value to it. And so if you could show people, if a patient to patient could show people, peer to peer, could show people why it is important for them to use it, they would use it.
Well, this is John. It's 10 o'clock Pacific. We've reached the end of the time we asked folks to dedicate to this, and so I think we should wrap up. Let me just say that I thought this was one of the best webinars I've ever been part of. And to Emory and Rosie, thank you so much. To everybody who asked questions, thank you so much. We got to a lot of them, but not all. And please send them along, or I think we might be able to figure out your email, and we can have the Emory folks or Rosie respond to your question, perhaps via email. So Amanda, unless you or Liz have anything else to say,
Yes.
I think we should call this a wrap.
Yes, I will just say we have copied the questions that we didn't get to. We will get answers to them, and we'll include that when we send out the follow-up with the recordings. So thank you so much to everyone for the awesome questions.
All right, thank you.
Thanks, everyone.